Welcome to Mercy Medical Center's live webinar. Today's topic is post-traumatic stress disorder. Joining us is Dr. Luke Hansen, psychologist at Mercy Medical Center. After his discussion, you will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Welcome to the seminar, Dr. Hansen. I'm going to turn the mic over to you now so we can get started.
All right, well, thank you for having me, and I look forward to some questions and good discussion later. I'm going to jump right into the material, starting with the objectives and what we'll be discussing over the next 40 minutes or so. I'll start with just some definitions and some of the criteria for PTSD, but we'll also start defining just what trauma and traumatization are and how sometimes we can experience trauma, or in fact most times experience trauma and not necessarily have that result in PTSD. I'll also talk about the epidemiology of PTSD. Obviously we know that it stems from experiencing a trauma, but also we'll talk about some groups of individuals that may be more vulnerable, as well as different types of trauma that may be more likely to result in PTSD. Again, we'll talk about the various risk factors that can result in people being more vulnerable, or also we will talk a little bit about resiliency factors and things that seem to protect certain individuals from developing PTSD. We'll also talk about some warning signs or clues, because a lot of times patients will not come in and say to their provider that they think they have PTSD. They may be more likely to express other concerns like depression, anxiety, physical symptoms, sleep concerns, or it may be a relative or a loved one or a spouse that actually expresses more concerns regarding the person's behavior. So we'll talk a little bit about what those signs and clues can be. Finally, we'll talk a little bit about treatment and effectiveness, including medication, but also non-medication approaches, and then talk about ways to prevent PTSD. Obviously, we cannot prevent, in most cases, trauma, but how can we prevent for ourselves or as providers for someone else? How can we prevent an exposure to trauma from reaching the point of post-traumatic stress disorder? So, with that said, jumping into what exactly is trauma and traumatization. Trauma is something which threatens one's physical or psychological or emotional well-being, essentially. So whether that's being hurt or being in a near-death experience, or witnessing something like that occur to a loved one, which would obviously be very emotionally or psychologically threatening to us, would qualify as a trauma. And then traumatization occurs when both internal and external resources are inadequate to cope with external threat. So once again, we can experience a trauma but not necessarily feel traumatized if we have internally whether it be the mindset or experience or wherewithal to deal with that situation, and also have the external resources such as support from others, shelter, all of those things that can often be threatened when a traumatic event has occurred. If we have those things, sometimes or a lot of the time we won't ultimately feel traumatized, but if those things are lacking, those internal and external resources, that's when the likelihood of traumatization and then possibly a post-traumatic stress disorder become more of a possibility. What is traumatic stress? Traumatic stress refers to the physical and emotional responses of an individual to the events that threaten the life or their psychological integrity, again, or of someone critically important to them. Once again, when we talk about traumatic stress, this is different than just experiencing a trauma. The resources aren't there to help us cope with and deal with the situation long term. As I'll get into here in a little bit, most people experience symptoms or feelings that might be consistent with PTSD initially after a traumatic event, but the vast majority of people are able to respond and recover without it developing into post-traumatic stress disorder. Down at the bottom there, traumatic events overwhelm an individual's ability to cope and elicit feelings of terror, powerlessness, and out-of-control physiological arousal. We'll talk about a number of those symptoms, including the physiological concerns, in a little bit. So what are the traumatic stress disorders? Traumatic stress disorders are disorders related to and or specifically resulting from trauma exposure. And while a lot of us have heard of post-traumatic stress disorder, there is something referred to as an acute traumatic stress disorder. And essentially the symptoms of the two, acute stress disorder and post-traumatic stress disorder, are identical with the exception that a time frame is what the key difference is. Again, a lot of people will have symptoms consistent with post-traumatic stress disorder within that first month, but most are able to recover to relatively normal functioning within 1 month. When we say relatively normal, obviously there may be some lingering thoughts, memories, feelings that are present, but not at a level consistent with post-traumatic stress disorder. When those types of symptoms, which we'll talk about in a little bit here, persist after a month period of time, then we would possibly meet criteria for post-traumatic stress disorder. So finally, getting to the definition of PTSD. First, it's important to know PTSD is the only diagnosis in the DSM for which there is a known cause. Obviously, we have a lot of research suggesting what contributes to or results in things like depression, anxiety, but we know by definition PTSD has to start with a traumatic event or trauma. In order to have PTSD, a person therefore must have been exposed to that traumatic event, and again, it has to have occurred over 1 month ago, so that we have seen that the individual has continued to have symptoms even after that month of recovery, that it's impairing their functioning, whether it be in relationships, work, physical care, ability to take care of themselves, and should have symptoms in the following 3 categories, which will be on the next slide here. So the symptoms fall into the 3 categories, and a different amount of symptoms are needed in each area to meet criteria. But the first category, where you often should see 3 symptoms or more to meet criteria, would be avoidance or numbing. And these include symptoms such as feeling distant or cut off from people, having trouble feeling that connection with others, feeling numb, and also just avoiding a lot of the triggers that remind a person of that event, like people, places, and things that are associated with the trauma, having that kind of force-shortened sense of future or impending sense of doom. And as we mentioned earlier, and we'll talk about later, you can see where this would possibly contribute to relationship issues or behavioral changes, and those types of difficulties can often be what prompts a person to seek help, or prompts their loved one to express concern and want the person to seek help. Second category of symptoms would be re-experiencing. This would include Symptoms such as intrusive thoughts or images, unwanted memories of the event, flashbacks, which are much more vivid experiences, almost as though one is back in the traumatic event. And again, feeling as though the event were happening again. Nightmares, vivid nightmares would also fall into that re-experiencing category. Finally, hyperarousal. 2 symptoms in this area would be required, and this would include feeling jumpy, easily startled, irritable, on edge, jittery. This can take different forms, but it's something that can be very much something that lingers and interferes with a person's life. I know well before I was on my way to being a psychologist, I was dating a young lady, and we were at a church party getting ready and blowing up some balloons. A number of us were, and her father had been in combat in Vietnam, and he was there, and some of us teenagers were getting carried away with the balloons and blowing them up too much, and they started to pop. And while that's enough to startle anyone, her father would actually essentially scream each time it happened, and his arms would flail, and he ultimately had to leave the room. And it was clearly not for any type of show. That was not at all his personality. It really still affected him in that way after many, many years of not having been in that combat type of situation. Okay, so just a few more tidbits or facts about PTSD and trauma. Again, it represents that failure of natural recovery following an acute stress. It is the 5th most common psychiatric disorder in the United States, though I would have to say, in my opinion, that may be an underestimation for multiple reasons. One, people may often underreport having experienced a trauma, either because perhaps they are embarrassed, perhaps sometimes they inappropriately blame themselves for it, or they may just feel as though they don't want to admit to it. I had a fellow I was seeing not long ago that was having some symptoms but was reluctant. He was a soldier that had returned from Afghanistan, reluctant to really identify it as PTSD. His wife had asked him if he had experienced anything traumatic in Afghanistan, and he said no. Yet the more she would see certain behaviors, for example, when they're driving in the car, if there's a wrapper on the road, he would swerve to avoid it fairly dramatically. She just really felt that things were eating at him more than he was acknowledging, and she then decided at a later date to ask, so was there anything that others might consider traumatic that you experienced in Afghanistan? And asking him in that way, he was more comfortable opening up about what others might have found traumatic that he endured in Afghanistan. And over time, he did begin to acknowledge that perhaps he was dealing with some PTSD symptoms. So I think another factor is also that sometimes providers may not ask about trauma because they may not feel equipped to respond if indeed the person has experienced a trauma, or may just feel like that's going to be an uncomfortable discussion to have. But we'll talk a little about that later when we get into prevention, about why that's important, because what can happen is that people then underreport and it goes untreated as a result. Trauma is a much more common experience than PTSD, affecting 61% of men and 51% of women based on the National Comorbidity Study. So again, this just goes to show the big discrepancy there. If that many people have experienced trauma in their lives, why is the number for PTSD so much lower? Part of that is because we do have that natural ability to recover, but part of that may be that people sometimes don't seek help or are under-reporting. Again, the incidence of PTSD is higher in specific high-risk groups, and we'll talk about this next. And there are certain types of trauma that are more likely to result in PTSD than others. The range of trauma exposure, again, is 50 to 80%, depending on how you're defining trauma. It is something that's nearly universal. Of course, we're all have the potential of being exposed to a trauma at some point in our life, though it's more common in certain populations, such as a seriously mentally ill population, foster care, and homeless. About 1 person in 10 in the U.S. suffers from PTSD in his or her lifetime, with 2 to 3% of those with current PTSD. So I mentioned some groups that are at higher risk. Here are some of them. Psychiatric outpatients, 20 to 30% higher rate than the average population. That even higher in urban psychiatric outpatients. SMI stands for seriously mentally ill, 29 to 43%. Female drug users, that score is, or that percentage is very high, perhaps reflecting some tendency to self-medicate in response to the trauma. SED stands for seriously emotionally disturbed, which is refers to children and adolescents with a severe emotional disturbance. And then others that are important to note are those going through complex medical procedures, and again, homeless and homeless mentally ill. Then, as I mentioned, there are different types of trauma that are more likely to result in PTSD regardless of who you are. Even though females obviously are more frequently the victims of rape, men have a higher rate of developing PTSD following rape than do women. This is about, I believe, the only category that this would be the case, the only type of trauma where men might respond more frequently with PTSD symptoms. Molestation, the numbers are 12% versus 26%. Physical attack, you can see that the female rate is much higher. This may have to do with the way in which we're socialized. Boys may be more used to the fist fight on the playground or those types of altercations, whereas females may not. Also, females are often, unfortunately, the victims of men in domestic situations, and physically may be more easily overpowered at times, and so that certainly the more likely results in the possibility of PTSD resulting, given the psychological factors and the likelihood for greater physical injury. Combat, we only have numbers on men, though just in the news this morning that they're talking about the possibility of females being able to serve in more combat-related situations. Physical abuse, 22% to 48% for females. Accidents, the numbers are a bit lower than compared to abuse and rape and combat. I would imagine that is because an accident can be, there can certainly be a wide range of outcomes for accidents and that type of thing, but it's still a substantial number. Disasters such as natural disasters, the numbers are still significant, but you can see they're fairly dramatically lower than abuse or combat. And that goes back to the types of resources that we have following a trauma. And this is not to minimize the experience that anyone out there may have had going through the flood of 2008, for example. But ideally, in a situation like that, we have a lot of resources that are offered to try to help us through those times. We're also surrounded by other people who are experiencing similar difficulties, and having that support and that understanding makes a significant difference. So while there may certainly be people who have developed PTSD symptoms following a disaster, the risk overall is lower statistically compared to other events. So again, any trauma, the risk is a little bit lower for men developing PTSD symptoms, though again that may have some to do with men being less likely to seek help for mental health concerns in general than women do. And then the overall prevalence lifetime is 5% to 10%. So again, going over some risk factors, we talked about different groups. Again, those with a psychiatric history of anxiety and depression, they may be a little bit more vulnerable to developing PTSD symptoms following a trauma. Family psychiatric history. So if one has kind of that higher genetic load for developing a mental health issue, they may be more prone to developing PTSD after a trauma. And early adversity. If we would like to think, I suppose, that having gone through difficult times before, that experience helps us in the future, and I think certainly that can be the case. But if we're young and we're also in a lot of situations where we are left to feel insecure, vulnerable, and not protected, then that actually is more of a risk factor down the line for developing PTSD symptoms in response to a trauma. Other things that are also relevant are the peri-traumatic response, and that really refers to kind of the reaction that we might have in the midst of or right after a trauma. And the best example I can think of is I have a patient that I've seen that has pretty strong PTSD symptoms that was in a car accident. She was actually in a string of about 3 or 4 car accidents, and she did pretty well after the first accident. She was able to get the car to a safe place and received help quickly, and things went about as well as they can as far as an accident goes. But for whatever reason, when she was in the second accident, she was hit. She remembers the car spinning. She remembers another car coming towards her. And she remembers in that moment thinking to herself, I'm going to die. And those types of responses, those types of memories in the midst of a trauma are associated with greater risk for PTSD than if the thoughts are more about less obviously overwhelming feelings like I'm going to die. If that person somehow was able to stay focused on what they needed to do to get out of harm's way, or were focused on assisting others, or whatever the case may be, that type of thing may be associated with less risk of developing PTSD symptoms after that 30-day period of recovery. Again, the psychosocial response after exposure, if we don't have good support from others, the risk is higher that we're going to develop PTSD symptoms. Prior trauma exposure, as I mentioned above, with early adversity, if you've experienced a trauma before, unfortunately, most of the time that does not mean that we're going to be less likely to struggle with PTSD symptoms after a second or third trauma. It actually means we're more likely to develop PTSD symptoms in response to another trauma. And last, we've talked a bit about gender on the previous slide. Men are more likely to be exposed to trauma, but women are more likely to develop PTSD. And that does not mean that women are somehow less capable of responding to trauma. It may be that they are just more willing to acknowledge difficulties and seek help. So unfortunately, the list of risk factors is much longer than the risk of resilience factors, and that's partly because there hasn't been as much research done in this area, though it is something that's being focused on more and more, and hopefully this will continue to be the case. it goes without saying that if a lack of social support is a risk factor, then strong social support is a factor that helps to create resilience in response to a trauma. But then there is also a term used called coping competence that has been researched more recently that seems to be associated with significantly reduced vulnerability to developing PTSD symptoms following a trauma. And what goes into this coping competence includes factors such as hope, faith, optimism, and of course practical resources. You know, it's easier to have confidence in our ability to cope if we have support, if we have shelter and food and those types of things. But the hope and faith really seem to be key. And from what I've read, even if it seems at times to be somewhat superstitious, or to some it may seem naive or Pollyannish, the person that just has this belief that, you know, sometimes or you know, when it's just the way things are. When I go through things like this, I'm just always able to bounce back, or whether it's one's spiritual beliefs that things will always work out, or things happen for a reason. You know, that can really sometimes seem insensitive when someone says that to you. You've gone through a trauma, to, you know, what reason on earth could this have possibly have happened to me? Explain that to me. It's you know, those words can sometimes feel hollow or empty, but those people that are able to maintain that hope or that mindset that there will be some good that comes out of this are typically able to have greater success avoiding the development of PTSD symptoms. So shifting gears here a little bit, I'm going to talk now about recognizing clinical clues for patients with PTSD. Again, as I mentioned earlier, whether it's a loved one, or sometimes we just aren't self-aware or want to kind of minimize or push away symptoms, or whether we're a healthcare provider for someone, it's important to be aware of perhaps some more subtle symptoms of PTSD that may not be the obvious flashbacks or the classical symptoms that we read about as being criteria for PTSD. Again, issues with attachment can be something that we see. The person starts to socially isolate. They have difficulties relating to others. There's the biological clues. It doesn't always have to be hyper arousal or that startle response, like I mentioned with the fella that was very startled with the balloons popping, but it can be issues such as greater insensitivity to pain or hypersensitivity to pain, hypersensitivity to physical contact, not wanting to be touched or being uncomfortable with that. That certainly can also be the case for people who've been physically or sexually abused as well. Affect regulation, just meaning difficulties controlling emotions, up and down, mood swings, or difficulties describing feelings and one's internal state. Dissociation, just feeling kind of detached, kind of like we're outside of ourselves, looking in, not remembering events, losing time. It can sometimes be symptoms that people will report as well. Behavioral control, poor impulse control, self-destructive behavior, substance abuse, we'll talk about in a minute, can also be seen. So these are the types of things that we may see from others that may not always initially indicate PTSD, but could be clues, especially if it seems to be a significant change from what we remember the person being like before they may have experienced a trauma. Cognition, problems focusing and completing tasks, being distracted, either perhaps because the person is preoccupied with thoughts of the trauma, or maybe just has a general difficulty with anxiety because they've experienced a trauma and their nervous system is kind of frazzled, for a lack of a better way to put it. Self-concept, and disturbed body image, low self-esteem, shame, and guilt. Of course, you're going to see those symptoms as a possibility for people who've experienced abuse, such as sexual abuse. Again, relationship concerns, hypersensitivity, trust and intimacy issues, again, especially if one has been abused, but that can be the case even if somebody's experienced a trauma that's not related to abuse. Somatic complaints such as sleep difficulties, that hyperarousal, the physical tension and pain, all of these are symptoms to be aware of for yourself or for someone you love or someone you're treating. Okay, and I think I already mentioned substance abuse. So that gets us through some of those clues to look for, and I'm going to now talk a little bit more about the different treatments that are out there for PTSD. And because we have a limited amount of time today, really I am going to be describing, some therapy approaches that are really, not easy to describe in a short period of time. These are approaches that people are trained in for a long time, or may go to multiple days of seminars and get training certificates and that type of thing. So I'll have to oversimplify it a bit, but these are the approaches that are found to be helpful. Of course, one that a lot of people have probably heard of would be cognitive behavioral therapy, or trauma-focused cognitive behavioral therapy, which would focus on, how we think about the trauma and the events that occurred and interpret those, and are there ways in which we can think about that trauma or our recovery that affect the way we feel and set us up for a better chance of recovery and improved coping. There's cognitive processing therapy, which is time-limited, structured, individual or group approach. There's something referred to as eye movement desensitization and reprocessing therapy, or EMDR. There may be some out there listening to this program that may even know more about this than I do. I am not trained in it. I believe there are some in the area that are. It does seem to have better results than placebo, though to some degree exactly how and why it works remains somewhat uncertain. From my understanding, the approach involves addressing the trauma that is experienced, and in the process, the person is asked to do a series of eye movements that may help to regulate their physiological response to a trauma. If you think about it, when we're in the midst of a trauma, everything is elevated. We're scanning quickly, heart rate is elevated, and essentially trying to reprogram ourselves physically, physiologically, as we discuss and work our way through the trauma that we've experienced. Again, if there's anyone out there that has more information, I would be happy to hear that as well. But that is something that's been found to be an evidence-based practice. Prolonged exposure therapy, and then disorder-specific couples therapy. So as I mentioned, PTSD can so very much affect a person's relationship, and there is an approach now that really factors in PTSD in terms of educating partners and the individual about how therapy can affect them, how partners can be more supportive and understanding, and incorporates that into a couples therapy approach. And for more information on that, there's a website link there at the bottom that you can look at. Essentially, again, while I may be oversimplifying it a bit, most of the therapy approaches that you'll see used for PTSD are follow kind of a three-stage approach. First and foremost, there's crisis management. You have to focus on making sure that you or your loved one or your patient is not in a situation where they are continuing to be traumatized, where you can't work through it or very easily manage PTSD symptoms if you continue to be in a situation where you're traumatized or around constant triggers of that trauma. So focusing on safety is a first stage. Second would be more of the working through, and then that it's a process, but retelling of one's story and identifying where that person is stuck and why they have been unable to recover in a way that ideally we naturally recover following a trauma. And different approaches may have a different way of addressing or getting to this second stage. One little exercise that I sometimes use as people are addressing these concerns in that second stage is I might have them do some journaling. I might have them write a bit about what they've experienced and encourage them to do so with different colored ink pens, so that when they reach a point where they're retelling their story, that they start to cry or they start to become angry or they just can't write anymore or they become confused, to start writing in a different color of ink and then to reflect on that and go back to those areas where we reach that point and see if there's something that's a key or a clue to why we are stuck and having trouble let go or moving forward in response to a trauma. And then finally, meaning making, which just refers to, how can I make sense of all this? We can't go back and change that the trauma occurred. How can I somehow pull some meaning, grow in some way from this experience and find a way for it to affect my life less in the future? Of course, there are some medication approaches. Antidepressants can be used, SSRIs, which would focus entirely on serotonin, or SNRIs, which would focus on our brain's neurotransmitters to include serotonin and norepinephrine, might help with those intrusive, unwanted thoughts or the social withdrawal or those numbing feelings. Mood stabilizers and atypical antipsychotics may help with irritability, aggression, agitation, impulsiveness, or flashbacks. Benzodiazepines or sedative hypnotics for that hyperexcitability or startle reactions or high anxiety. Of course, addiction history should be closely evaluated, particularly for that last category, as some of those medications can be overused or abused, and individuals with PTSD can be at a greater risk for abusing substances, so that's something that would have to be used with caution. As far as veterans go, some of the studies that have been done, veterans diagnosed with PTSD do usually receive medication in response, and most commonly prescribed are the antidepressants, followed by the anti-anxiety medications, the benzodiazepines, the sedative hypnotics that might help with sleep as well, and then 34% those antipsychotics to help with perhaps more aggression, impulsiveness, flashbacks, or those types of symptoms. In terms of prevention, there's research that suggests that corticosteroids and propranolol are promising with regards to preventing combat-related PTSD, though I would venture to guess that this could be said for PTSD that's not related to combat. But these medications would be, the reason they would fall into the prevention category is because these wouldn't necessarily be medications that would be the first line of treatment for someone who's had PTSD for years, these would be medications that shortly following a trauma exposure that are given to someone to help control their physiological arousal. May slow things like heart rate, blood pressure, those physiological clues that kind of send the message to ourselves that we're in danger, and if we can regulate our bodies in that way, perhaps the sense of danger is lower, and the likelihood of developing PTSD symptoms therefore is reduced. Outside of the medication approaches, though, it really goes back to what I was talking about earlier on, which is that the best way to prevent trauma, other than to keep ourselves safe and not in traumatic situations, is to have an increased awareness of just how prevalent trauma is, as well as the symptoms of trauma, the signs and clues that are evident, because it's just one of those things that is not at all easy to talk about, yet is important to talk about. I know that I've gotten in the habit, as far in researching this, that it's interesting to look at when I go to a physician's office. They have you list history of diabetes or your medications or all of these things that you've had or experienced in the last year or whatever else the case may be. And most often I don't see a line or a checklist for any type of trauma, even though we know very well that they can have a major impact on a person, not just emotionally, but physically as well. So that's why the third bullet there, universal screening is recommended. Once again, a symptom of PTSD in and of itself is avoiding triggers. So, by definition, people may avoid talking about it, and it goes undiagnosed or missed too often if it's not asked about. And then the last thing I just will repeat is that it's important to assess for, because even if a person doesn't meet criteria for PTSD, they can still have issues in their life that may be related to a trauma that they need to address. It may not be a level that we would consider PTSD, but trauma can have an impact on us in a variety of ways. So I'm just going to end here with some different resources, some websites that you can look at, jot down, or print out, and then I will turn it back over to Lynn here.
Well, thank you for educating us about such an important topic. And to remind our listeners, your questions can be submitted from the box in the upper right-hand corner of your screen. And we'll take a look at our questions here. The first question, are there any support groups for people with PTSD?
That's a good question, and again, if anyone knows of resources that I'm not aware of, I would love to hear of those for my own sake and for the sake of my patients, and it's also something maybe that we can then post in our offices or on our website. At this point in time, I am only aware of PTSD support groups that are available through the VA. In Iowa City, I've had a young man that's attended that group. I would venture to guess that they might have something at the outpatient clinic here, VA clinic here in Cedar Rapids, but I am not sure. There are a number of support groups for anxiety and depression and related symptoms, but I'm unaware of specific groups here locally for PTSD specifically. So if there are out there, let us know.
Okay, well, then a question related to that, would it be helpful for a person with PTSD to attend a support group for people with the symptoms of it, such as the anxiety or depression support groups?
I think that certainly that would not be a bad idea. I mean, anytime, again, uh, we talked about resilience factors. Anytime you can have support and feel like others understand you, even if they haven't gone through a trauma, but perhaps they understand the feelings of anxiety and depression and not knowing exactly how to cope with those at times, that's going to be beneficial. But I think because some PTSD symptoms are quite a bit different and specific to PTSD, such as, the flashbacks, the nightmares, the numbing, the irritability, and that type of thing. If there is a PTSD group or a group for individuals with that have experienced certain types of abuse, that may have an added benefit for an individual.
Next question here. If left untreated, can you expect just more severity of the mentioned symptoms, or can other problems then arise?
I think that's a really good question as well. I think you certainly would expect the symptoms to persist. You would expect them to most likely worsen as well, but I would definitely say while it might look different for different people, other problems could certainly arise. We talked about things like hypersensitivity to pain or issues like that. A person might start to develop odd or unusual physical symptoms and seek treatment in that way because subconsciously they're not addressing some of the trauma-related issues. They're seeking unnecessary medical care, which can result in other complications or health issues, so it can unravel or snowball from there. Certainly it can result in further mental health symptoms as well. If we're starting to struggle in our relationships because we feel disconnected from other people or uncomfortable with being touched, then depression can become more of a factor, or anxiety, and pretty soon the PTSD can be buried under these levels of other issues and never gets addressed. So that's a very good question.
When a person is in treatment, what is the typical length of treatment, and what is the success rate for people with PTSD?
There is the VA has started to be really aggressive with the treatment and education regarding PTSD. Just because of how many soldiers have come back and have struggled or have committed or attempted suicide. So I do not know the exact numbers on the success rate. That's an excellent question. I need to find that out for further presentations. But I know that it's from what I've read, that it is improving and certainly is far better than no treatment. But as far as the typical length, there are different approaches. The approaches I mentioned, like EMDR or cognitive processing therapy, are time limited, ideally 12 to 18 visits of different stages and steps that one goes through, and ideally the person feels relief following those 18 sessions. However, because we're just such complicated creatures and different traumas can be, different, and a person's background can be different, that really I have found is no way to easily predict what that length of treatment is going to be like. It also depends on whether or not that person is still around their triggers of trauma and whether they're still kind of in a crisis situation. Because again, then you can't make your way through those stages of treatment if you're still in that situation.
Okay. Next question, what should you do if a person experiences a violent episode, such as re-experiencing the event? I'm not sure if there's enough information there, but perhaps you can address that question.
Well, obviously, you would need to do whatever you can to keep yourself or that person safe. Obviously, if this person has previously been in a combat situation, if you can avoid threats of violence in return, or can somehow manage the situation by keeping your calm, that would be important. But if it has reached a level of violence, if you can get that person help, probably contacting law enforcement, one, to make sure that they're safe and that you're safe, but also law enforcement can then not necessarily help you take legal action, but get them to a place get the person to a place where they can start to receive help, have them assessed in an emergency room where they can be evaluated to determine if they're going to continue to be a threat of violence, and whether or not medication might be of help, and get them linked to treatment.
Okay, and next is a comment and then a question stating it's always better for a person to seek and receive treatment on their own. This listener said people should be aware that in Iowa, people can seek an involuntary court committal through the Iowa court system so the person can be evaluated. Would you like to, make any comments about that?
Yeah, that is an important point to be aware of, and kind of piggybacks on what I was just talking about. If it's a situation where there has been a violent event or indication of that type of behavior, but no one is now imminently in danger, so in other words, you don't have to contact the police right now. A loved one, along with usually another adult, can contact the court or go to the courthouse and file papers that essentially document how the individual has become a threat to others or a threat to themselves, and therefore needs treatment. And I would agree with the first part of that as well, that treatment is overwhelmingly more likely to be beneficial if the person wants it and sees the need for it, rather than if it is forced upon them. But sometimes an involuntary committal is necessary for safety reasons, and a lot of times I have seen where a person is involuntarily committed, but while they don't want to be there initially, sometimes after the dust settles and the seeds have been planted, with time and reflection, that person may come to the conclusion that they want or need to change for themselves.
Do many wives contact you out of concern about their spouses?
Well, as I mentioned before in that example, the fellow whose wife asked him initially did he experience trauma, and then backtracked and asked him in a different way, okay, did you see anything that others might experience as traumatic? She has gone on to share with me that she knows of a number of other women with similar concerns. And I would say, in answer to this question, that I have had multiple spouses or partners come to me, maybe not as it being their initial concern. Maybe they're struggling with their own depression or anxiety, or come in concerned about marital issues, and then over the course of our discussion, as we talk about things, it may become apparent that perhaps their spouse's or husband's behavior is related in some degree to a trauma of some sort.
And a related question, you mentioned couple therapy during your presentation. Is this available in the Cedar Rapids area?
You know, this is something that I just had forwarded to me by the Consortium for Mental Health at the University of Iowa, and I've just read about it and included it in my my presentation here. So I honestly don't know how many or if there are therapists in the area that are certified in this couple-specific PTSD-specific couples therapy. I think it's something that's likely to grow, though, as evidence supports it, and then more formal training will occur. But I think really what you'd want to be interested in is if you and your spouse are struggling with marital issues and you believe that a trauma that one of you has experienced is a part of that, that you would want to know from your therapist whether or not that therapist has experience in treating PTSD as well as doing couples counseling. As long as they have an awareness of what the symptoms are and how it can affect one's behavior, I think that's really the most important thing, that not be neglected as a couple is working on their marital issues.
And interesting, we just had a comment come in from one of our listeners that says the Cedar Rapids Vet Center does couples and family counseling, and this is for combat veterans only. So thank you for sharing that. A tape of this program will be available at the website at the bottom of your screen, mercycare.org/live, and within the next day or so. And you can always check this website for information about future webinars and listen to past webinars. Our next webinar topic is Helping Kids Cope, Understanding and Managing Childhood Anxiety, and this will be led by Ellen Daly, a counselor at Mercy Family Counseling. It will be held Thursday, February 21st at noon to 1, and she will take your questions live after her discussion also. If you are interested in future Mercy webinars or other educational events, you may sign up for Mercy's electronic newsletter, and that's available on sign up at www.mercycare.org/e-news. I believe we have covered all the questions submitted to us, but if you have additional concerns or questions, Dr. Hansen can be reached at 319-369-4777. Thank you all for joining us today.